Introduction, and thank you for the invitation. Lifetime management is a very important topic to me, and in the United States, it's something that becomes more and more discussed because in the United States, even for people under the age of 65, almost 50% of patients get TAVI. This is a population where the majority of patients are bicuspid, and the data for the treatment of patients with age less than 65 is very limited. As you know, we have a lot of options for treating aortic stenosis. We have surgical AVR with a mechanical or bioprosthetic valve. We can do root enlargement or root replacement, although it's done rarely. And we can use high frame or low frame valves. Question is, does surgical AVR still have a role in 2023? And I would argue that the data for surgical AVR is actually excellent. This is data from the recovery trial showing 3-year survival of 100% basically. So they had 0 mortality. The surgery can fix leaflet calcifications, can deal with calcium in the outflow tract, can deal with coronary heights, can do many things. They can extract the leaflets. So surgery certainly needs to be a very important part of the discussion. How about mechanical aortic valves? They theoretically last forever. They have a slightly higher risk of infection. And if you're under the age of 54, you actually get a survival benefit from a mechanical aortic valve. The problem is that in the United States, people are not putting in many mechanical valves because of the need for anticoagulation. Patients simply do not want them. So how about these fancy surgeries that can be done and unfortunately are done very rarely? A surgeon can enlarge the aortic root or can replace the entire aortic root and reimplant the coronaries. If you are in an experienced center with a good surgeon, your outcomes should be similar to standard AVR, even though pump time and blood loss will be increased. Unfortunately, this is being done very rarely, even in big centers in the United States. So how is the decision made on who's going to get surgery or who's going to get one of these fancy surgeries? And the answer is most of the time the decision is made by the surgeon intraoperatively, relatively in a vacuum. A lot of surgeons who might be willing to do this type of surgery are going to be reluctant to do it on an ad hoc basis. They would like to have their senior partner around, they would like to have somebody else, they would like to have prepared differently. And the good news is that we can prepare the patient and we can find out ahead of time whether this will be necessary. This is data showing that if you do a CAT scan on patients, you can very accurately predict the size of the valve that will be implanted. And you will either estimate correctly or you will overestimate. You will never underestimate the size of the valve that the surgeon will put in. And once you have that information, you can estimate the patient's risk of patient-prosthesis mismatch. And if you know that the patient is at high risk of patient-prosthesis mismatch, then you know that potentially they need an aortic root enlargement. So how about TAVR? The long-term durability is somewhat limited. We don't have a lot of information for that. We think that the long-term durability is similar as with surgical AVR. But the data is limited in duration. We have good data from bicuspid trials, a lot of it originating in Asia. There's a lot of experience with that, especially here. The problem is that most patients who are included in bicuspid trials go through a screening process, and the exact details of the screening process are not clear. There is no clear quantification method to tell you that this patient should have a TAVR or should not have a TAVR. There's a lot of times when it says, excessive calcium, excessive raphe calcium, but what excessive means, nobody tells you. The other problem with TAVR is that we've been dealing with a lot of older people, and complications that may be acceptable in older people are not going to be accessible if you're dealing with 50-year-olds. We know that pacemaker and aortic regurgitation after TAVI is not a good thing. Recently we found out that even with mild aortic insufficiency, your outcomes are bad. So avoiding pacemakers and perivalvular AI is important if you're doing young people. We know that coronary access can be a problem, and we have to be cognizant of that. If you have an 80-year-old who has no coronary artery disease, it's very unlikely that they're going to get coronary artery disease in their lifetime. With a 50-year-old, there is a good chance that you're going to have to deal with the coronaries in the future. So we have to think about that. So how about TAVR in surgical AVR? We do a lot of this in the US. These are the risk factors that predict difficulty in putting a TAVR in a surgical AVR valve. We can do all these fancy things, balloon valve fracture, basilica, unicorn procedure, snorkels, but I would argue that these do not belong in young people. If you're young and you need a basilica, you're probably better off having surgery and having definitive repair or replacement. Certainly, these techniques have a role in older people. They have a role in people who have no other options. But again, in healthy young people, they shouldn't be used. The other thing that I hear a lot is, well, this person may be 70 and maybe they're not going to live that long. Why do we have to bother about a second valve? The reality is that a second valve may happen a lot earlier than we think because there can be implant problems. The valve can be placed too high or too low. It can be underexpanded, overexpanded, and all these things affect valve durability. Also, patient compliance. We had a patient, for instance, who did not take any antiplatelet therapy and was lost to follow-up for 2 or 3 years, came back with a severely degenerated valve that had to be replaced. So how about TAVR in TAVR? We know the risk factor for coronary occlusion with TAVR in TAVR. These were well published and well described. This is one of the seminal papers from Okiai telling you how to assess the risk of coronary obstruction and sinus sequestration. Commissural alignment can be done with self-expanding valves. You fall within about 30 degrees. The problem with commissural alignment is that the coronaries are not always aligned with the commissures. And especially in bicuspid valves, the coronaries may be somewhere where you don't expect them to be. So what we need in the future is coronary alignment rather than commissural alignment. So how about SAVR after TAVR? This tends to be a bloody proposition. We recently have data that shows that the outcomes are quite bad with valve extraction. All the bad things happen, prolonged ventilation, stroke rate, mortality is increased. Certainly TAVR in TAVR is going to be safer than TAVR explant. And a lot of times you need to repair the ascending aorta or you need to replace the mitral valve. So probably if you're going to plan on a patient having an extraction, you should go with a smaller valve, a smaller frame valve. So a couple of case examples. This is a 57-year-old who had a 27 millimeter perimount placed 5 years prior. The valve has now failed. He's 57. And he has no option to put in a TAVR valve. The coronaries are way too low, as you can see, less than 6 millimeters for the right and 6.5 millimeters for the left. And the distance to coronaries is about 1 millimeter. Can you do a basilica in this situation? Absolutely you can, but what are you going to do in 5 or 10 years when it fails again? So I would argue that this patient needs not only surgery, but he shouldn't have just a valve replacement. He should actually have his anatomy addressed so next time around when the valve fails, he can have a TAVI in there. Or just put a mechanical valve. But this is an example of where the surgical technique really needs to be adjusted for future TAVI in TAVR in SAVR. This is another case of a failed 34-year-old 34 millimeter evolute with severe central AI. You can see that the valve to coronary distance was tight and the coronaries arise below the risk plane. If you try to put a valve in there, you have a high risk of occlusion. So you have to take these things into account, especially in younger people. So how do we put all this together? Well, the older I get, the more I want my procedures to be boring and simple. I think surgery is more complex than TAVR, but can be very safe and reproducible in many patients. I think that complex procedures should be avoided unless there is a need to do something very complex. And you have to be knowledgeable of what your center can do and what the community can do. If you need to do complex surgery like an aortic root enlargement or replacement, you're better off doing it at a young age than waiting until the patient is 70 or 75. I think the initial valve choice is very important. you have to take into account not only the patient's immediate risk from the procedure, but you have to look at their entire risk over a lifetime. So the risk of, let's say, 2 TAVI and 1 SAVR, or 2 SAVR and 1 TAVI. And the problem is that the current risk calculators that we have are very limited. For instance, the STS PROM calculator does not take into account any sort of root enlargement or root replacement. And the TAVR risk calculator does not take into account basilica or TAVR in SAVR or TAVR in TAVR. So these are my proposed principles, and we're trying to put them in a paper and publish it soon. I think ideally everybody would get only 1 lifetime sternotomy maximum. I think that a CTA and multidisciplinary valve team consultation should be offered to all patients considered for bioprosthetic heart valve, not only for the patients considered for TAVR. I think it's much more important to know what the life expectancy is rather than the age. Coronary access and avoiding pacemaker placement and perivalvular AI are very important. We need to figure out this lifetime risk rather than the immediate risk, and we have no tools at this point for that. And in certain patients, it may be reasonable to start with TAVR first, planning to allow for extraction or other procedures in the future. And if you're going to explant, probably use a low frame valve. Avoiding high-risk procedures is important in all cases. So this is how I put it all together. Everybody needs a CTA. There's no ideal sequence of SAVR versus TAVR. And you can start with either valve depending on the anatomy. You need to know what the anatomy is, and that's why the CTA and the valve team decision is critical. So this is a proposed pathway that I'm working on together with a team from Columbia in New York. So I think anybody who's got a life expectancy of less than 5 or 6 years really shouldn't be considering surgery unless there's a good reason for it. If your life expectancy is less than 5 or 6 years, then you really should be considering TAVR, and if TAVR is not an option, then you unfortunately have to go to palliative care. If the patient is a surgical candidate, or if the patient has reasons to have more extensive surgery, then you have to determine whether their anatomy permits future TAVR and SAVR and quantify their lifetime risk. Once you're looking at a patient that you're considering SAVR, what we propose is basically first looking at the potential for patient-prosthesis mismatch. If there is potential for patient-prosthesis mismatch, then you have to examine whether aortic root enlargement or replacement is an option. If there is no potential for for patient-prosthesis mismatch, then you have to evaluate the potential to have TAVR and SAVR. Now, if you're considering a patient for TAVR, similarly, you have to estimate their level of risk, and this is very subjective. We have no calculators for this. And once the level of risk has been quantified, then you have to look at whether the patient will be able to have TAVR and TAVR. So, again, looking at a 57-year-old that I showed you earlier with the 27 millimeter perimount, you could come up with a calculation something along these lines. So basically, you could say the patient could have had a mechanical valve. This is their lifetime risk. The patient could have now a mechanical valve the second time around. This is their lifetime risk, but they have to take anticoagulation. Or you can factor in all these various combinations of TAVR, SAVR, whatever. The problem is that we don't have a calculator for this yet, but I think that this is the approach that will lead to a solution in the future. So with that, thank you very much for giving me the opportunity to present, and I'll take any questions.